I'm Changhyun Kang in Seoul National University Hospital. I really thanks to the committee members for inviting me to this important meeting. Today's presentation is about the thoracoscopic segmentectomy. I will mainly focus on the technical advancement and the recent issues on the thoracoscopic segmentectomy. Before starting the segmentectomy presentation, I must introduce a book about the segmentectomy. This book was written by Dr. Nomori and Dr. Okada in 2011. This book contains detailed anatomical description about the pulmonary arteries and pulmonary veins, and contains a very detailed technical aspect about the segmentectomy. The basic technique used in this book was using the electrocautery by dividing the segmental plane by using electrocautery and covering the segmental plane using the PGA sheet and fibrine glue. Today's presentation will be about the technical advancement since the introduction of the basic principles of segmentectomy in this book. The first aspect that I will mention is about the anatomy. Because segmental anatomy is very complex and subsegmental anatomy is more complex to memorize. And sometimes there are so many variations on the segmental anatomies in the pulmonary artery, pulmonary veins. So although in the textbook we can see the very beautiful anatomy description on the segmental branches, however in the real patient it cannot be applied correctly. So individualized anatomical understanding is very important. And preoperative 3D reconstruction is very necessary to completely understand the anatomical variation of each patient. This is one of the examples that we are using in our hospital, the Synapse PACS system. This system is based on the shape recognition technology, like as a face recognition in the AI technology. And the other features of the advantages, this system makes a very fast reconstruction. Just 5 or 10 minutes, it can reconstruct all the 3D reconstruction images. And the other feature is easy to use, as in very easy, even for the residents or trainees, they can use this program very easily. And we used this program several years, and I think the usefulness of this program is the identification of interrelationship between bronchus, arteries, veins, and the interrelationship is very important especially in the complex segmentectomy. And the other one is determination of a safe resection margin is possible using the preoperative remodeling of the exact location of a tumor and the distance from the bronchus and pulmonary arteries. The preoperative 3D reconstruction has been reported in many papers. In 2015, Chan and colleagues reported the 3D reconstruction is helpful in pathologic margin clearance. They compared the radiologic location and pathology location, and they could very high correlation rate between radiologic and pathology location. In 2017, Kato reported they did just a 3D reconstruction guided segmentectomy without preoperative tumor localization or marking. And they concluded that the 100% of patients was possible, and it is a very safe and effective method if the segmentectomy is planned and preoperative localization is maybe not necessary when we using the 3D reconstruction. In 2020, Q and colleagues reported what is the benefit of a 3D reconstruction. They said the complex segmentectomy, it may be beneficial for the patients. And after 2020, several papers are published comparing 3D reconstruction and no reconstruction. And Chen and colleagues reported their randomized controlled trial, you comparing 3D reconstruction and no reconstruction, and 3D reconstruction decreased the conversion rate, operation time, and blood loss. And Wu and colleagues also similar paper in 2021. Although this paper was a retrospective paper, the result was very similar. The 3D reconstruction decreased operation time, air leakage duration, and ensuring adequate resection margin. So many papers currently are being published about the preoperative 3D reconstruction, and most of papers reported the same finding. The 3D reconstruction is helpful and improve the surgical outcome in VATS segmentectomy. The other issue is intraoperative segmental margin evaluation. There has been many different types of margin evaluation methods. I listed just the three representative methods to identify the segmental margin. The first one is a selective ventilation. The second one is a intravenous ICG injection. The other one is a bronchial ICG injection. The rest one requires a navigation bronchoscopy. And in terms of the difficulty, an intravenous injection is the most easiest way, and the clearness margin is the most clear in the intravenous ICG injection. And the selective ventilation is sometimes clear, but sometimes in patients with COPD or some respiratory lung disease, it is very unclear. And however, if we think about the theoretical role of segmentectomy and removing the segmental lymphatics altogether, and the bronchial delineation is a theoretically correct one because the lymphatic flow follows through the bronchial pathway, not the arterial pathway, and sometimes the arterial pathway does not exactly match with the bronchial pathway. However, the intravenous injection also has advantages because we can identify the non-perfused area correctly and remove the whole non-perfused area. But in the bronchial delineation, it has a chance to left the non-perfused area in the residual lung. Now, what will happen if the residual non-perfused area, we don't know. Maybe in some of the severe cases, maybe infarct, or other cases, maybe pneumonia focused. And what is my practice? My preference is using the IV ICG injection because it is simple and the direct way to identify the segmental plane. But it requires some of the paper, which one is better and which one is worse in the real practice of the segmentectomy. After identifying segmental plane, we must choose the way to resect the lung parenchyma. And there has been two kinds of methods. The first one is electrocautery. The next one is the stapling. In terms of the technique, stapling is much easier than the electrocautery because the electrocautery requires an identification of intersegmental vein and maintain the segmental plane and not to injure subsegmental bronchus or arteries. And then in terms of the lung volume preservation, electrocautery is better than the stapling. However, whether the preserving the small portion of lung volume may affect the actual lung function is controversial. I will show the clinical result in the next slide. However, the most important complication of electrocautery is a high rate of the air leakage. So sometimes we can see the very high rate of the pulmonary complication after electrocautery. For parenchymal division method, there has been many different types of method. Each surgeon has their one technique, and so hundreds of thousands of different ways for the controlling the parenchyma exist in the world. However, I choose just 5 papers, which is representative and which has some meaning in the understanding this issue. In 2011, Asakura and colleagues reported that stapling reduced the pulmonary volume in pig model, not a human model. And this finding is now generally accepted as a correct one because the stapling and reduced the expansion volume around the stapling line. In 2012, however, Osuke and colleagues argued about the outcome of the segmental resection because electrocautery increased air leakage complication than stapling, and this is some kinds of starting point. And 2017, and Saito and colleagues reported a very interesting paper. They just cut the segmental plane and then suture the pleura and approximate the pleura just like as a stapling, and then compares the air leakage and the lung function, and they could find that and found that the post-op air leakage was reduced and the lung function was not different. And 2019, Tao and colleagues also reported a similar result. And stapling, although it increased the size of resected surface, however, the lung function difference was not clear. And finally, 2020, and Chen and colleagues reported a randomized controlled trial comparing stapling and electrocautery. and they concluded stapling decreased the post-op complication, but however lung function was not different. So currently, and the recent papers reported that stapling reduced the complication, especially for elderly kids. However, lung function difference was not so great. So generally, it is now believed that stapling is comparable to electrocautery and reduced the complication. Currently, my practice is using the stapler, and in the initial phase of the segmentectomy in mid-2000, I used the electrocautery. However, because of high rate of persistent air leakage, I abandoned the electrocautery. I am now currently using stapler exclusively. However, stapler induced the lung volume loss, and it is necessary to modify the stapling method to maintain the lung volume. The first one is a dimensional stapling, and not making a stapler in the unidirectional, but making the stapler at bidirectional or tridirectional, and then we can reduce the lung volume loss. And it is a so-called making a Benz emblem, like as a 3-star Benz emblem of the auto car maker. But this is not a new story. Already 10 or 20 years ago, our senior staffs already mentions about it, that if after finishing the segmentectomy, if we can make a Benz emblem, we can consider the segmentectomy was done very properly. The other method is the making of extensive dissection for the central area and lifting the segmentectomy lung volume to upside, and then finalize the segmentectomy using the stapling for the peripheral area. This is a very common technique. And then this photo was taken by Chen Chun, and he named this technique as a dimension reduction technique. And whatever the name is, this is a very useful technique for the complex segmentectomy. For my personal practice, in a simple segmentectomy, I use this one, dimensional stapling, just the stapling. And for the very complex segmentectomy, for example, the basal segment or anterior segment, I usually like to do extensive dissection around the central area. This is a technique. And finally, I must conclude my presentation. I think a segmentectomy is a valuable surgical option for early stage lung cancer. And furthermore, it is a promising surgical method considering current medical and social trend. And to achieve high quality segmentectomy with a low complication rate and good long-term survival, planning is important. Preoperative planning and intraoperative assessment is also important, and proper application of surgical technique is also necessary. And combination of this planning, assessment, and application may be a very important point to achieve a very good segmentectomy result. Hopefully, and I anticipate following studies, especially for long-term outcomes of each specific technique and application of newly evolving technology. And thank you very much. Thank you for your attention.